This might happen to the blood vessels of your hypertensive patient if the blood pressure is not well controlled. In order to control the blood pressure, there are two modalities are available.
Medical management, lifestyle management.
First, let's study about the lifestyle management. We have exercise and we have diet. When we talk about the exercise, we have to do at least 150 minutes per week of aerobic exercise. And when we talk about the diet, we have to have the clean diet, and remember that we have to add potassium and magnesium salts in our diet rather than so much of sodium salt. Whenever we start the medical management, there are two questions: whom to treat and how to treat. In the subsequent few seconds, we will answer this question. When we measure the blood pressure of these patients, we get two sets of patients. One who have less than 140 by 90 mm of Hg blood pressure, and another who have greater than or equal to 140 by 90 mm of Hg blood pressure. When we consider the patients who have blood pressure less than 140 by 90 mm of Hg, these patients usually we don't treat unless and until they have the coronary artery disease or they have the risk of coronary artery disease and their blood pressure lies in between greater than 130 by 80 mm of Hg and less than 140 by 90 mm of Hg. In such situations, we give only monotherapy of drugs for these patients, that is single drug therapy. Whenever we consider the patients whose blood pressure is greater than or equal to 140 by 90 mm of Hg, again we will divide this group into two subgroups. One which is greater than 180 by 110 mm of Hg. For this we have to start treatment immediately, which is pharmacological obviously, and another patients who lies between 140 by 90 mm of Hg and 180 by 110 mm of Hg. We call these as grade 1 and grade 2 patients. These patients we have to start a lifestyle management of 4 weeks initially, and then we have to start a pharmacological management if they are not managed in the lifestyle management. One important thing to remember is, in a broad spectrum 140 to 180 people, usually we start with the lifestyle management, then we go for the pharmacological management. But European Society of Hypertension also says that if the blood pressure is greater than 150 bar 95 mm of Hg, it's better to start pharmacological management rather than the lifestyle management directly. Now in the pharmacological management, we usually follow the ABCD criteria. That is A for ARBs greater than ACE inhibitors, B for beta blockers, C for calcium channel blockers, and D for diuretics. Nowadays, beta blockers are no longer the first line drug. A, C, D are the first line drugs. Nowadays, we consider dual therapy rather than the monotherapy. Whenever we consider dual therapy, there are two options, either A plus C or A plus D. Whenever we consider A plus C, we have Telma AM, that is telmisartan and Amlong. Telmisartan, the dose starts from 20 milligrams and we can give 40 milligrams and we can go till 80 milligrams. Similarly, amlodipine, we can start from 2.5 milligram, go till 5 milligram and 10 milligram also. And on the other hand, whenever we consider A plus D, we have Telma H, that is telmisartan hydrochlorothiazide, usually available in 40 milligram plus 12.5 milligram fixed dose combination. That is 40 milligram of telmisartan and 12.5 milligram of hydrochlorothiazide. If the patient's blood pressure is still not controlled after giving the double drug regimens, we can go for the triple drug regimens. Whenever we give triple drug regimens, that is telmisartan, amlong or hydrochlorothiazide or any combination of A plus C plus D, if still it is not managed, we have to rule out the secondary hypertension causes or any other causes of hypertension. If all the causes are ruled out and still it is primary hypertension, then we can go for spironolactone. Only and only if his kidney function tests are completely normal, that is his GFR value is greater than 30. If the GFR value is less than 30, we can add chlorthalidone. Now, as I've said that beta blockers are no longer considered the first line drugs and we don't use them regularly. But there is an exception. If a person is suffering from hypertension plus coronary artery disease, we usually prefer the A plus B regimen, that is ARBs and beta blockers. One of the example to name is BISO-T, that is bisoprolol and telmisartan combination, which is available as 2.5 and 5 mgs. And if the person is not responsive to the A plus B regimen, then we can go for A plus B plus D regimen. And further we can follow the same treatment regimen as previously.